Welcome. My name is Meredith Melnick, and I am the health director at the Huffington Post and today's moderator. This hour-long program, Cancer and Diet, the latest on processed meats, fat, and more, is a collaboration of the Forum at the Harvard T.H. Chan School of Public Health and the Huffington Post in association with Harvard Health Publications. This event is also part of the Dr. Lawrence H. and Roberta Cohn Forums. As some of you may know, Dr. Cohn passed away unexpectedly a few days ago, and we're deeply saddened by the sudden loss. He was a renowned cardiac surgeon and a major member of this community and a major supporter of the Forum. And we are so grateful to him and to his wife, Roberta, who made this event and the others in the Cohn series possible. He touched many lives, and I know that he'll be very missed. So I'd like to turn over and introduce today's panelists, starting to my right. Walter Willett is the chair of the Department of Nutrition at the Harvard T.H. Chan School of Public Health. Frank Hu is a professor of nutrition and epidemiology at the Harvard T.H. Chan School of Public Health. Edward Giovanici is also a professor of nutrition and epidemiology at the Harvard T.H. Chan School of Public Health. And Marjorie McCullough is the strategic director of nutritional epidemiology at the American Cancer Society. This program will include a brief Q&A, and you can email questions to the forum at hsph.harvard.edu for those of you watching remotely. You can also participate in a live chat discussion that's happening on the forum website right now. And I think we'll get started. So Dr. Willett, can you help provide some context here? What is the current thinking on the connection between diet and cancer risk, and how has it changed over the decades?
Sure, I think it's helpful to go back in time a little bit. The idea that diet may be a strong influence on cancer risk is actually fairly new. When I was in medical school back in the 1970s, no one really wondered or asked about or said anything about how diet might relate to cancer. And it was during the 70s that several epidemiologists started to put together data on cancer rates from different countries around the world. And the picture that emerged was really striking. There were 5, 8, 10-fold differences in cancer rates among different countries. For example, breast cancer rates in the United States were about 8 or 10 times higher than in Japan and a number of other countries at that time. Now, one alternative explanation is that this might be due to genetic factors. But other epidemiologists were looking at people who moved from low-risk countries like Japan to the United States, and what they found was that the populations who moved adopted the cancer rates of people living here, which said clearly these huge differences are not due to genetic factors. There were some clues from these international studies that diet might be an explanatory factor. For example, that national consumption of saturated fat was strongly related to breast cancer, colon cancer, and some other cancers. But these are pretty crude kinds of studies, and we really needed more information. Nevertheless, this very limited, weak kind of evidence got translated into conventional wisdom and national guidelines, and it became the conclusions of our dietary guidelines that total fat in the diet was the major thing that we should focus on reducing. That began in the 1980s. And so we went through a period until fairly recently where the recommendations from all kinds of organizations was get all fat out of the diet as much as possible, which means we really need to load up on carbohydrate. But recognizing that these were weak studies, we put into place some large cohort studies where we enrolled several 100,000 individuals across the United States and tracked their diet carefully over time. Of course, the first thing we looked at was fat and cancer, and we just didn't find any relationship, dietary fat and cancer. And we looked at that repeatedly in lots of detail, others did, and what's emerged is that there really is no important relationship between total fat intake and cancer risk. However, fat in the body is a big risk factor for cancer, and that wasn't really appreciated early on. But it's not a simple translation from we eat fat and it makes us fat, because we can also get fat eating carbohydrate. In fact, that's turned out to be even more important. We also found that fruit and vegetable consumption had much less impact on cancer risk than we thought before. And one of the factors that did emerge as being related to cancer risk was consumption of red meat, especially red meat, processed red meat, in relation to risk of colorectal cancer and some other cancers. So that's briefly where we are today, and I think Dr. Giovannucci is going to be able to provide some more detail on what is the evidence from studies around the world on red meat and cancer.
Yes, and so the red meat and processed meat cancer connection obviously was big news recently. I'm sure you all saw with the World Health Organization making headlines and suggesting that there is this link and calling red meat a probable carcinogen. So we actually have a short video that we're going to play that sort of delves into that announcement.
Now, yesterday, the World Health Organization's new report that bacon and other processed meats are cancer-causing nearly broke the internet. Here are just a few examples of Twitter users sounding off. Someone says, bacon causes cancer? Well, I'm going to try to eat it all so no one else has to suffer. Not all heroes wear capes. Or, my Uncle Billy had bacon and eggs for every morning of his 96 years. If he'd eaten tofu, he would have died at 65 from boredom. Just saying. And the National Pork Producers Council also chimed in, tweeting, world's oldest woman, 116, eats bacon daily. Now, the health organization now puts processed meats in the same category as smoking and asbestos. And other reports from this week suggest that cheese and sugar are as addictive as drugs. And did you know that 10% of vegetarian hot dogs contain meat? So basically, what is left out there that you can eat to stay healthy?
We'll return to the use of anecdotal evidence on Twitter later. Dr. Hu, I'm wondering, beyond the World Health Organization, the latest dietary guidelines, it's the other big nutrition news, the U.S. Department of Health and Human Services, and the U.S. Department of Agriculture, they were just published, and you served on the advisory committee. And I'm wondering if you could talk a little bit about how those guidelines differ from some of the information coming from the World Health Organization and how they mirror each other.
Well, let me start with a few words about the process of developing dietary guidelines. It's a long process. So by law, every 5 years, the federal government has to update and then release the dietary guidelines for Americans. Before they do that, the USDA and the HHS convene an expert panel to review the latest evidence on diet and health and then develop a scientific report. So I was very privileged to serve on the 2015 Dietary Guideline Advisory Committee, or the DGAC. The committee spent almost 2 years reviewing a huge amount of the literature on nutrition and health, and then developed the 2015 DGAC report, which served as the scientific basis for the federal government to develop the dietary guidelines for Americans, which were released last week. So the new dietary guidelines, I think, contain most of the recommendations made by the committee, but they also contain some deficiencies or omissions. So let me talk about some positive features of the new dietary guidelines first. In terms of improvements over previous dietary guidelines, this is the first time the dietary guidelines actually set a limit on added sugar intake, which is 10%, no more than 10% of calories coming from added sugar. This is very important because consuming too much added sugar has been linked to diabetes, heart disease, and even some cancers. Another improvement is that the dietary guidelines actually remove the upper limit on total fat. As Walter just mentioned, total fat is not that important in terms of heart disease, cancer risk, but the type of fats are much more important. So the new dietary guidelines put more emphasis on certain type of fats and recommend people to reduce saturated fat and replace saturated fat with healthy fats, such as polyunsaturated fats, rather than carbohydrates. And also the new dietary guidelines put more emphasis on overall healthy eating patterns, including the Mediterranean diet pattern, the healthy vegetarian patterns, and those patterns can be adapted according to individuals' food and cultural preferences. So I think those are all important improvements of this addition of new dietary guidelines. As I just mentioned, there are several important omissions in the new guidelines. First of all, environmental sustainability, which is a major topic in our DGAC report, was declared out of the scope of the dietary guidelines by the USDA from the beginning due to heavy pressure, political pressure from the meat industry, from the Congress. And another important omission is that the new dietary guidelines do not explicitly recommend people to cut back on red and processed meat. Although this is a very important recommendation made by the committee, instead the new dietary guidelines advise people to include lean meat as one of the healthy protein choices. So this recommendation is certainly not consistent with the WHO recommendation or the DGSA report. Another issue has been raised is that the soda recommendation is a bit diluted in the new dietary guidelines, even though this is the first time the dietary guidelines set a limit on added sugar intake. The main recommendations do not include soda reduction. We know that soda is a major source of added sugar. So those are, I think, important omissions in the new dietary guidelines. Having said that, I think there are many positive elements in the new dietary guidelines, and if those recommendations are implemented, it can lead to important public health benefits.
So just to continue talking about some of the different ways that we're approaching these two topics together, Dr. Giovannucci, I'm wondering if you could, as a panel member of the World Cancer Research Fund, you could tell us a little bit about, how you've approached this question of diet.
Sure. Yes, the World Cancer Research Fund, or WCRF, is based in the UK, and it has a sister organization, the American Institute of Cancer Research, or AICR, in the United States. And the whole focus of the organization is diet and cancer. So every year we have meetings and we've reviewed the evidence. Currently I'm lugging around a 200-page document reviewing the evidence for esophageal cancer, only one type of cancer. Basically, as Dr. Willett mentioned, prospective studies are important. And in the past 20 years, based largely on the model of the Nurses' Health Study, there have been many prospective studies across the world, and they're producing tons of evidence from diverse populations. Now, obviously, there's so much detail to get into, but broadly, the main recommendations after sifting through all of this evidence, almost every study that's been published, we sift through. The basic findings, as Dr. Willett mentioned, is obesity. The most important dietary related factor for cancer is being lean, is being protective, and being physically active. And that's the number one message. Now, in terms of that, how do you get there? Well, obviously, we're not going to focus only on preventing obesity is a big topic, which we're not going to get into. But there is an emphasis on more of a plant-based diet, partly that it may help prevent obesity, but there may be some beneficial compounds in plant foods, even though that seems to be, there's a lot of controversy. The evidence on fruits and vegetables is not as strong. And at the same time, it's important to note when we say plant-based diet that we should exclude starchy, processed starches and sugars, which are plant-based, but are probably not healthy. So, and in terms of the animal foods, the evidence seems to be very consistent across many studies now, particularly for colorectal cancer, that red meat and particularly processed meat increased risk. Just to give you a sense of the data, there have been about 30 prospective studies of colorectal cancer and colorectal adenomas, which are cancer precursors, in diverse populations. And very consistent finding has been in association with processed meat. If you pull all the data together, about 50 grams a day of processed meat, which is 2 ounces for Americans, is associated with about a 20% increased risk of colorectal cancer. And that's been a very consistent finding. In terms of mechanisms, which is important to understand because there's some controversy over this, I think there are a lot of plausible mechanisms. Heme iron, which is a type of iron in red meat, actually, which makes why is white meat different? There's about 10 times more iron in red meat. That may be a factor. But that needs to be worked out. But the epidemiology is very consistent in showing an association with red meat, particularly processed meat, and colorectal cancer. I think I'll stop at this point.
Yeah. Dr. McCullough, you were an observer in the meeting that produced the World Health Organization's report. I'm wondering if you could talk a little bit about that, and then also, how do you think the report was received? Was it received the way the writers intended? What are some of the misunderstandings you've seen, if any? And just if you could tell us a little bit about that.
Okay. Well, when the IARC announced its classification of processed meat as a Group 1 carcinogen and red meat as a probable carcinogen in relation to colorectal cancer, I think a lot of people were confused and a little bit alarmed because some of the headlines read that processed meat, that bacon was equal to tobacco in terms of cancer risk. And to be clear, the IARC considers an exposure to be a Group 1 carcinogen if there's sufficient evidence to say that it causes cancer. Tobacco is an established cause of at least a dozen cancers. So if you smoke, the most important thing to do to reduce your cancer risk is to quit smoking. As far as processed meat is concerned, and I wanted to mention also, if you do not smoke, which 80% of Americans, that applies to 80% of Americans, the next best thing you could do is modify your lifestyle, and that's your diet and other lifestyle factors. So for processed meat, Dr. Giovannucci mentioned the risk with each additional serving of processed meat. And the risk estimates are similar for red meat, which was considered a probable carcinogen. Now, relative to smoking, those are modest, but if you eat a lot of red and processed meats, the risk can really go up, and a lot of people do eat a lot of red and processed meats in this country. Also, colorectal cancer is the third most commonly diagnosed cancer in U.S. men and women, and the third most common cause of cancer death in this country. So if we can identify anything that's a modifiable risk factor, that could be very important for prevention of cancer. And I also want to mention the American Cancer Society publishes guidelines on nutrition and physical activity for cancer prevention every 5 years. And in those guidelines, there's 4 key general recommendations, and that's maintaining a healthy body weight throughout life, being physically active, and eating a healthy diet pattern, rich in plant foods and low in red and processed meat, which, by the way, has been in our guidelines since 2002, so we've known about that for a long time. And then lastly, if you drink alcohol, do so in moderation.
I'm so glad that you mentioned that you've sort of taken us in the direction of talking about risk reduction and prevention, and that's what we're going to be sort of focusing on for the second half of this presentation. And I think we're actually going to start with a video produced by Sherwick in collaboration with the American Cancer Society about reducing cancer risk through diet and weight control.
We're working very hard to determine which cancers are specifically related to what you eat and what you weigh. One of the strongest associations, interestingly, is with cancer of the esophagus, breast cancer, particularly if you gain weight after menopause, cancer of the uterus, which we call endometrial cancer, the lining of the uterus, pancreas cancer, kidney cancer, colon cancer as well. All of these have a relationship, an association with overweight and obesity. We do have some evidence that in certain types of cancers, like breast cancer, endometrial cancer, possibly colon cancer as well, that you can alter your risk, particularly well established in breast cancer following menopause. So we have the strong suspicion that losing weight, if someone is already obese, will reduce their risk, and absolutely it is the best and clearest recommendation that I have to reduce your risk. People can affect their risk of developing cancer, and they can do it by starting at a young age, adopting a healthier lifestyle with the right foods, being physically active, and striving to attempt a near normal body weight.
So I think based on that video, one thing that we should talk about is how meaningful lifestyle changes really are in terms of overall risk. And Dr. Willett, I want to turn it to you and to talk a little bit about red meat, cancer risk, of course, but also generally, red meat and health. What are some of the...
Right, well, thank you. Obviously, the focus on the World Health Organization report was cancer, and that was the focus of our topic today. But of course, when we're making decisions regarding our diet, we can't look at just one organ at a time or one disease at a time. We have to look at overall health. And as part of the studies that we put in place to look at diet and cancer, we've also been tracking pretty much everything else that happens to people: heart attacks, strokes, diabetes, dementia, everything. And we found that red meat is also related to risks of other important diseases like heart attacks, stroke, and diabetes. So it's not just, there may be a modest increase in risk of cancer, but when you add up all these other adverse relationships with red meat, it actually becomes quite important. And if you look at total mortality, there actually is a clear dose-response relationship. The more red meat, the more processed meat we consume, the higher our risk of overall premature death. So it does make a really important difference. Of course, it all depends on what you replace red meat with. If it's donuts and other things like that, it's not going to be beneficial. But if you replace it with other protein sources like poultry, fish, vegetable sources like tofu, beans, there's really important benefits that cut across a lot of different diseases.
Yeah. So I'm wondering if we could talk a little bit more about the idea of individual dietary choices, so replacing red meat with tofu and beans, et cetera, versus weight control. Obviously, these are important in concert, but just in terms of talking about the differences in terms of their risk reduction, what sort of differentiates them?
Well, I could maybe tackle that one, and others may add something, but one, I think, important concept that's developed over the last decade or so is that diet quality, the combination of foods, the pattern of foods, is important in directly influencing disease risk, but also in helping us better control our body weight. So these we used to think of were sort of separate things, but now they're intertwined. And the kind of dietary pattern that Dr. Hu was talking about, like a Mediterranean diet that has lots of fruits and vegetables, low amounts of red meat, whole grains, that actually makes it easier for us to control our weight than eating a diet of refined foods that's directly unhealthy but also makes it more difficult to control our weight. So that's convenient. We're the same diet that is good overall for health helps control weight. Of course, other things like physical activity are very important in maintaining a healthy weight throughout life. So it's a combination of factors.
Yeah, one area I want to mention is that the bacteria in our gut may actually provide a link between red meat and other type of foods in our diet and body weight and other health outcomes. There is fascinating research showing that if you ingest red meat, some of the components are broken down by the bacteria, and that lead to the production of unhealthy compounds or bad compounds like TMAO, which has been associated with inflammation, insulin resistance, atherosclerosis, and even cardiovascular disease in humans. However, when people switch from a meat-based diet to a more plant-based diet, the type of bacteria and the abundance of bacteria will change very, very quickly. And so the type of bad bacteria that lead to the production of the harmful compound will be reduced, and also the metabolite called TMAO is also going to be reduced. So it means that when you make dietary changes, cut back on red meat, your gut bacteria are going to be much healthier, and the gut microbiome may actually play a very important role in terms of improving our body weight and other health outcomes.
So that reminds me a little bit about another question that I had about age and, at what point these interventions are meaningful. And what you're saying is that there is this sort of almost not immediate but short-term change. I'm wondering if you could speak to that. How does is it always useful to make this change? How useful is it later in life if you've lived on a steady diet of meat and potatoes for decades?
maybe I'll try that one again too. It is impressive that changes even very late in life, such as even being older and having a heart attack, dietary change can within a matter of a few months drop our risk greatly of a recurrent heart attack or death. So it's never too late to make important changes. For diabetes also, that if we change our diet, almost immediately our risk of diabetes goes down. But that's not to say you should just wait till you're old to start living a healthy life. We're seeing in some studies now that what women ate as adolescents, especially if they ate a lot more red meat, that affected breast cancer risk later in their life. So it's definitely important if you want the healthiest overall life is to start a healthy lifestyle early. But if you've sort of ignored things, it's never too late to still get some benefit.
Absolutely, yeah.
Yeah, just to expand on that point a little bit, for cancer, it's a little bit complicated because cancers they develop over many years. And so, but what we're finding in general for obesity-related or physical activity, those factors seem to act late in the process, so you do get benefits by reducing weight or maintaining your weight or exercising within a relatively short time. Probably because those factors are related to hormones, estrogens, insulin, that are drivers of tumors. There may be another group of factors, as Dr. Willett mentioned, that early exposure is more important. So for example, for folate, which we found as a protective factor for colon cancer, it seems that your status 10, 20 years earlier is what is relevant, so you may not get an immediate benefit. But for weight maintenance and reduction, you get an immediate benefit.
And I'll add that people can dramatically reduce their risk of developing or dying from cancer, cardiovascular disease, or of any cause by adopting these cancer prevention guidelines, and indeed many other overlapping guidelines. In our own study at the American Cancer Society in the Cancer Prevention Study cohort, it's a cohort of older U.S. men and women. We looked at how many people's lifestyles were consistent with the recommendation to maintain a healthy body weight, to be regularly physically active, to eat the overall diet pattern that is low in red and processed meat and high in plant foods, and moderate in alcohol consumption. And people whose lifestyles were most consistent with that overall, those overall guidelines, compared to people whose lifestyles were least consistent, had about a 25 to 30% lower risk of dying from cancer, and even greater for cardiovascular disease. It was 48 to 58%, and then for any cause of death it was 42% lower risk. And this has been replicated in a couple different large studies and has also been conducted by WCRF as well. And it's worth noting that the BMI component was the strongest, as we would expect, but the other components were important as well. So when you do all of these things together, it has a greater impact. And they might not be the most exciting things, because it's probably stuff you've heard about over and over again, but it's what works.
I'm wondering if actually we can return to the topic of sugar-sweetened beverages and alcohol in terms of these sort of applications of transforming your diet. How important is that in terms of cancer risk, in terms of obesity, in terms of all of this stuff?
Can I start? Yeah. So I think the evidence is quite clear that overconsumption of added sugar, especially sugar-sweetened beverages, is linked to various adverse health outcomes, especially obesity, type 2 diabetes, cardiovascular disease, and even some cancers. Right now, the consumption of added sugar in the U.S. population is very high. It's about 13 to 14% of calories which come from added sugar, and half of the added sugars actually come from sugar-sweetened beverages. So there is no question that the American diet is too sweet, and that's actually associated with very bitter consequences. We have a very high risk of obesity, type 2 diabetes, and as has just been mentioned, obesity is a major modifiable risk factor for cancer. So I think reducing sugar-sweetened beverage consumption will have important benefit on prevention of the cancer and the reduction of cancer risk.
Can I just add to that a little bit? That sugar-sweetened beverages really do stick out like sore thumbs in this area. Here, the averages are bad enough, but the problem is that it's not that everybody eats the average, and we find millions of Americans eating double the average, almost 30% of their calories from sugar. And there's a very substantial part of the population that has 3, 4, 5 servings of sugar-sweetened beverages per day. So it's not just the average that's killing us. It's unfortunately a lot of people, just like tobacco. We don't smoke an average amount of tobacco as a country. It's hitting some people particularly hard. Often, unfortunately, in people with the lowest income, the lowest education, lowest resources. That the soda industry really preys on these people, unfortunately, and there's a terrible amount of suffering and premature death that comes because of that. So many things contribute to obesity, but overwhelmingly the big factor is soda.
Yeah, just to add a little bit to, I agree with that point. In the WCRF, it's interesting that in their 10 commandments of dietary factors, number 1 is weight, 2 is physical activity, and 3 is sugary beverages, which is interesting because there are not many studies that directly link sugary beverages to a specific cancer, but just that the impact of obesity is so important, and the impact of beverages, sweetened beverages on obesity is so important. So you put the two together, and that's where the recommendation comes from.
So we have a packed house. I think we're going to have a lot of questions, and so I thought maybe we would turn to the questions. And Lisa, first, do you want to give us a question from the online audience?
Yes, and thanks, Meredith. We do have a lot of people concerned about their turkey and bologna sandwiches right now. They're all writing in. So this first one is from Sharon Fisher, public health educator in the Tobacco Control Program at Broome County Health Department. I'm curious about the definition of processed meats. I understand that pork and beef-based processed meats contain nitrates and definitely fit into this category. But what about poultry-based processed meats? For example, plain turkey breasts with no ingredients other than water are available. Does this product carry an increased risk compared to fresh roasted turkey breast, since it can be classified as processed meat? Is there something inherent in the processing that increases the risk, or is it the combination of ingredients added to most processed meats? Thank you for discussing this.
Okay, well, so according to the International Agency for Research on Cancer, the definition of a processed meat is meat that's been transformed through the addition of salt and nitrates, and or that's been smoked or fermented or used other methods to transform the meat to enhance flavor or to improve preservation. So that's the definition. And so technically it applies to white processed meats as well as red processed meats. And there have been a few studies that have looked at compared the two, but there's not a lot of evidence. So I think future studies really need to focus on trying to separate out the two. But because they've had the addition of these compounds, they are considered something that you should try to limit.
Thank you for clarifying that, Margie, because the people we're getting a lot of questions about that. So.
Great. And did you want to do another?
Great, yes. This is from John Williams from the Ashland School Board in Ashland, Oregon. Debate over the effects of antioxidants on incidence, proliferation, and treatment of cancers appears to rage on today despite 20-plus years of study. Can you identify a pathway towards answering these important questions, especially with regard to the huge popularity of antioxidant supplements? These questions can be tough.
Well, if nobody wants to say anything else, it's still an unsettled area. I think part of the challenge in general in studying cause and prevention of diseases like cancer that develop over decades means it's very hard to do the perfect ideal study. That the perfect ideal study usually would be to randomly assign tens of thousands of people to, say, more antioxidant intake and the others to a placebo and follow them for decades. But it might need to be 30, 40 decades. It takes about that long for smoking to show up as a risk factor for lung cancer. So if we're really with antioxidants blocking the early stages of the effects of smoking on lung cancer, the studies would need to go many decades. So the studies so far, randomized trials that have been done, don't show much benefit. There was actually a surprising increase in lung cancer with beta-carotene, one of the antioxidants, in people who smoked and were heavy drinkers, although there was no increase in risk in people with physicians who were generally pretty healthy to start with. So even the randomized trials give different answers. Another way is following, as we do, many hundreds of thousands of people for decades. And there the answers, I think, are that antioxidants are not a magic solution to cancer or other diseases, but there probably are some benefits. One example is that in the Physicians' Health Study randomized trial over 12 years, at the end of that period of time, those taking beta-carotene had better cognitive function than people on placebo. A really interesting and potentially important finding. So we don't have, it seems surprising, but even after several decades, we don't have a clear answer. There's not, if there were really across the board powerful benefits, we would have seen it. And that's not the situation. There may still be some benefits, but even if there are, that's only a small part of the changes that we need to make in diet and lifestyle to reduce our risk of cancer. As Margie mentioned, there's so many other things that are really quite well documented.
I just want to add that the dietary guidelines do not recommend supplements to get adequate amount of nutrients. The primary recommendation is to eat a healthy diet to meet the nutrient requirements. But for certain subgroups, vulnerable groups, such as pregnant women, of course, they need folic acid supplementation. And for elderly who may have B12 deficiency, they may need B12 supplementation or multivitamin supplementation. But overall, the dietary guidelines are very clear. The supplements are not a substitute for a healthy dietary pattern.
Yeah, definitely not a substitute. There are still areas where there's ongoing research, like vitamin D you can't get from a diet in any appreciable amounts. And some ongoing studies that are very important in that area.
Right. There is actually an interesting finding from the Physicians' Health Study showing that multivitamin supplements reduce cancer incidence or mortality by 10%. That's a very large randomized clinical trial. Joanne mentioned is now conducting another trial in women to see whether these results can be replicated.
Yeah, just to add that there's some evidence, multivitamin, which is meant more to replace deficiencies going up to the RDA, that may be beneficial. It's a little bit unclear, but at least it doesn't appear to be harmful. But for cancer, there is some, as Dr. Willett mentioned, some studies that suggest high doses of so-called antioxidants might actually be harmful. So in the WCRF guidelines, one of the 10 commandments is do not use supplements to reduce cancer risk.
Thank you for addressing all this because we are having a lot of questions on that. If I can do one more and then we'll go to the studio audience. It's along the same lines. Do foods high in calcium protect against cancer, and can calcium supplements be protective? Also, there have been a number of questions about calcium in particular.
Do you want to talk about that, Ed?
Any additional?
Want me to?
You can go ahead.
Yeah, calcium has been somewhat of a controversial topic. For colorectal cancer, actually, there is some evidence mainly from observational epidemiologic studies that higher calcium intake is actually beneficial. There have been some randomized trials that have had conflicting results, but at least some of the results have been positive, even from randomized trials. But on the other hand, there is some evidence for prostate cancer. It's it could be calcium or perhaps something else related to dairy consumption that tends to be associated with an increased risk. So we have a different pattern for colorectal and prostate cancer. So it's actually been unclear, but there is certainly some evidence for potential benefit for colorectal cancer. Maybe Margie would like to comment because she's done work in this.
Right. Well, I agree with what Dr. Giovannucci just said, and that's one of the complicated things about developing guidelines, because if calcium or dairy products reduce the risk of one cancer but increase the risk of another, I think people who are at risk of these cancers should discuss and weigh the pros and their risk with their physician.
Maybe to add to that just a little bit, that this is a really complicated, there's hardly anything more complicated than the calcium topic because it has pluses and minuses. And of course, a lot of this is about dose. And I think one thing that's become pretty clear is that the recommended RDA levels of calcium are higher than we need to be consuming, actually. It's an essential element, though, so we need some calcium. Dairy is the main source. So if somebody's taking 1 or 2 servings of dairy a day, they're almost for sure getting enough calcium. We get bits and pieces from lots of other places in the diet as well. But if somebody's not taking any dairy products, then it's reasonable to consider a supplement. But probably 500 milligrams a day, not more than 1,000, will get people into a very sufficient range of calcium. The problem is that there was a lot of enthusiasm about calcium supplementation, and a lot of foods are being fortified with calcium, and then people take this RDA over 1,000 milligrams of calcium. You can easily get 2,000 and 3,000 milligrams of calcium, and I think that's a level to be concerned about. So dose is really important in this area, and it's one of the things that makes nutrition complicated, because many of these things are absolutely essential, but for almost every essential nutrient, it's possible to get too much on the other end.
Yeah, there is also some preliminary evidence that taking calcium supplements is actually associated with increased risk of cardiovascular disease. That was based on the post hoc analysis of the Women's Health Initiative. It seems that women who were assigned to the calcium supplement group had higher risk of developing cardiovascular disease, and people were assigned to the placebo group. Of course, this is a post hoc analysis, but certainly it's a warning sign for people who are taking high dose calcium supplements.
So let's open it up to you here in the room. Does anyone want to ask a question? We have a mic to go around.
Hi, I'm Kate Darren. I'm from Simmons College. So with the recent release of the Dietary Guidelines, the media seem to be focusing a lot on alcohol consumption. And in looking at the evidence myself, it just seems that alcohol, and actually the specific type of alcoholic beverage you're consuming, affects your disease risk differently depending on what disease you're looking at. And I was wondering if you have found that to be true, and if we could get some practical recommendations for alcohol intake in terms of servings or number of drinks.
I could try to respond to that, but alcohol is another one of these things, like calcium, really complicated because there are benefits and there are harms. And that balance of risks and benefits, to quite a degree, depends on who you are and what your risk of disease is. The main benefits of moderate alcohol consumption are reduction in cardiovascular disease, and that's the number one cause of death in the United States and almost every country around the world. So a 20-30% reduction of cardiovascular disease is actually pretty important. But there are harms, and definitely with higher alcohol intake. But what we've shown in our studies and surprised a lot of people, but it's been reproduced in dozens and dozens of studies, is that even half a drink a day, like 1 drink every other day, will increase breast cancer risk in a measurable way, modest but measurable way. So for a woman who's under age 50 and is not smoking, the risk of cardiovascular disease is extremely low, but breast cancer risk is pretty real, and the other risk related to accidents, crashes, adds up, so that there's really, for such a person, there's almost only negative effects of alcohol consumption. But for somebody, a person who is 65 and has some cardiovascular risk factors, a 20-30% reduction would, with moderate alcohol consumption, would shift that to a beneficial side. So it's a really complicated area, something that needs to be individualized and good to talk about with your physician.
So the good news is that the dietary guidelines have been very consistent about alcohol consumption. So since 1980, the dietary guidelines recommend for those people who choose to drink alcohol, they should drink moderately. Of course, depend on how you're going to define moderate drinking. In the guidelines, moderate drinking is defined as one drink for women, 1 to 2 drinks for men. Certainly, I mean, even with this moderate level of consumption, there are benefits and potential risks. And the guidelines have been very cautious about making recommendations on alcohol, and specifically recommend people who are not drinking, they don't need to start to drink alcohol to get health benefits. And also, the guidelines do not make recommendations on specific type of alcohol beverages, wine versus beer versus liquor, because there is no sufficient evidence to make this type of recommendations at this point.
Just to add on to these points, as Dr. Willett mentioned, the risk of breast cancer in women, which makes it particularly complicated in women. In men, alcohol, a lot of people think of cancer as an outcome. And a lot of the previous studies they really hasn't teased out smokers from non-smokers. So we actually did a study that was published earlier this year, or I guess last year, that showed that at least up to 2 drinks a day in men who are non-smokers, never smoked or smoked very little, there really wasn't much of an impact of alcohol on cancer risk. We couldn't really go much beyond, but at least up to 2 drinks a day seems fairly safe for men if they're non-smokers.
And I'll add that in the American Cancer Society, we've got a very large cohort that we've been able to disentangle some of these associations by smoking, and we do still see increased risk of cancer with, in large part, it's a few drinks a day or more for some cancers like esophageal cancer, especially, and liver cancer. But as far as the breast cancer risk and weighing the risks, if you are somebody who is at high risk of breast cancer, also there's many other ways also to lower the risk of heart disease too. So pay attention to other heart disease risk factors.
Other questions from the audience?
Thanks very much for the great forum. My name is Greg Kerfman at Harvard Health Publications. And in regard to dietary sugars, getting back to that topic, are the adverse effects of sugar in the diet, let's say on cardiovascular disease or cancer, mediated only through increases in body weight, or are there other effects, adverse effects of sugar? And secondly, are there any differences between different types of sugar, for example, glucose and fructose?
Let me start. This is a really complicated question because we're looking at different types of sugar on various health outcomes. But in terms of your question regarding whether the sugar effects are entirely mediated by body weight, we specifically look at this question in terms of diabetes risk and the cardiovascular disease risk. For diabetes, it looks like 40 to 50% of the adverse effects are mediated by body weight or obesity. But sugar-sweetened beverages or added sugars do have some unique harmful effects beyond body weight. For example, fructose, which is metabolized in the liver, has been shown to be related to increased free fatty acids, de novo lipogenesis, and non-alcoholic fatty liver disease. And those conditions have been associated with increased insulin resistance, type 2 diabetes, and even cardiovascular disease. So it seems that body weight, of course, is an important mediator of the effects of sugars on health outcomes. But there are some other pathways or some other mechanisms that are unique to sugars and metabolic health.
Could I just a little bit, and you might ask Frank Sachs, who's sitting right behind you, about this too, that some of these adverse metabolic effects of sugar are in common with carbohydrates in general, especially refined carbohydrates and potatoes. Frank conducted a very nice trial published in a different medical journal, NGM, I think it was, the OmniHeart study, looking at carbohydrates compared to unsaturated fats or compared to protein, and with by those comparisons, carbohydrates in general elevated blood pressure, elevated triglycerides, depressed HDL cholesterol. So I think with this, a lot of attention on sugar, we should not forget this other big part of the diet that's refined starches and potatoes that has adverse effects. So part of this sugar effect is mediated as part of this overall unhealthy carbohydrate load. And the problem with sugar, of course, with sodas is that what's become standard 20-ounce serving of soda is you get 17 teaspoons of sugar there. It's just so easy to put down. The amount is always important, and so you can put down this huge amount of carbohydrate, unhealthy carbohydrate, very quickly, and people go back for another one right afterwards too. So it's partly, especially in liquid form, just so easy to consume very large amounts of something that has unhealthy effects, as Frank said, above and beyond the impact on weight control over the long run. So it's why this area does really deserve a lot of emphasis. And it's unfortunately why the earlier emphasis on fat reduction as the primary recommendation was, I think, a major factor in contributing to the epidemic of obesity and diabetes that we have today, because when people reduce fat, they inevitably have to eat more carbohydrate, and 80% of the carbohydrate in the U.S. diet is refined starch, sugar, and potatoes. And you eat a lot of that stuff, and you sort of see what we got.
I think we can take another question. Yeah.
Hi, my name is Uyao. I'm a student from here, like THN School of Public Health. So we've been discussing a lot about obesity, but I'm wondering how about underweight people? Like for those people who already have a pretty healthy diet, but they still are sort of underweight. How can they balance between trying to gain some weight and their diet patterns? Thanks.
We don't have many.
Very often.
we don't have many underweight people in our population. But the people who are kind of on the lower spectrum of the so-called normal weight categories, so BMI 18.5 to BMI 22. So our recent studies indicate that for those people who eat a healthy diet and they're physically active, they don't smoke, and they have lean body weight, their risk of developing cardiovascular disease, cancer, or premature death is actually very, very low, even compared to those who have relatively higher BMI, still within a normal range, and still eat a healthy diet and following a healthy lifestyle. So I think that the main issue is how do people achieve this lean body weight. If they achieve the lean body weight through healthy diet and lifestyle, I don't think it's necessary to worry about that much. However, some people become low body weight or become underweight due to some other reasons, such as chronic disease, malnutrition, and so on and so forth, and then that would be a cause for concern.
Yeah, maybe could I just a little bit and even go farther down, that actually in the Nurses' Health Study, the women who had a BMI of 17 had the optimal mortality in the long run, which would be in the underweight, below 18.5, so it's well within what's called underweight range. And that's a very complicated group of people, because some of those women are very healthy, they're active, they're eating a healthy diet, and they shouldn't worry about trying to increase their weight. It includes, though, a lot of chronically ill people or heavy smokers, and some people who have anorexia as well, which is definitely not healthy. So it's why this group often looks like they have overall an increased mortality in this underweight range, but it's such a heterogeneous mixed group that we, I think, have to be very careful. Some people are ill, have a serious condition like anorexia, but there's a lot of very healthy, especially women. It's very, very unusual to have a man who has, by hormonal reasons, bigger bones and bigger muscles. Very unusual to have a man with who's healthy below a BMI of 19 or so. But there are a lot of healthy women in that range, and they shouldn't be compelled, if they're eating well and active and otherwise healthy, to try to put on weight.
So before we wrap up, I actually would love to ask each of you the same last question, which is, what is one policy recommendation, and if you could sort of wave a wand, what is one policy recommendation that you would make to help educate and influence people in terms of their dietary patterns and disease risk?
You're looking at me?
I'm looking at you. I'm looking at all of you. Let's start with you, Dr. Well.
Yes, it is a tough question, because I think anybody who's looked at this this area understands that there are many, many different factors that get us in the dilemma that we are with so much obesity and diabetes, and therefore there's never going to be one factor that has more than a modest impact. We have to take lots of actions simultaneously. But if you're allowing me only one, I would really focus on sugar-sweetened beverages by multiple strategies: taxation, warning labels, limits where it can be served. It has so many adverse effects. I would put and we are putting a lot of our effort there.
I guess my hope is that the environmental sustainability will be put back to the dietary guidelines. And there is good evidence that a healthy diet is not just good for our health, but also for the health of the planet. And many countries like Denmark, Sweden, Australia, Brazil have already included environmental sustainability as part of their dietary guidelines. So I think it's really important for future DGAs to embrace food sustainability as part of the dietary guidelines.
I was going to pile on sugar-sweet beverages like Dr. Willett, so I have to come up with something else. I agree with Dr. Willett. It's multifactorial. This is one part of it, obviously not the only part, but I think physical education in schools is important. Some schools in the news have been cutting back on that. And I think that's a mistake. In fact, there's even beyond physical health, there's some evidence that it may help in school academically. So it makes no sense to cut back on that.
Well, so I agree with what they've all just said. And I think we need to make it easier for people to follow healthy diet and physical activity recommendations. And a specific policy recommendation is to support reauthorization of child nutrition programs, which is going to be coming before Congress soon. And the overweight and obesity rates in children are still unacceptably high, and we're setting those kids up for being overweight and obese adults, which is a huge threat for them, for cancer risk, but risk of other diseases certainly.
Great. Well, thank you so much for this really wonderful discussion. And for those of you who are on the website, online viewers, continue the conversation at the forum website, which is forumhsph.org. And please tune in to the next forum, which is going to be on Tuesday, January 26th, same time, 12:30 p.m. And the topic is preventing gun violence as a public health perspective. So thank you very much.